Coconut is going to introduce our grand round speaker. Jamie Anderson is in the back. This is sort of an extension of one of Jamie's research projects, and Chris and Jamie went up to Oregon to do a site visit on this program we're going to be talking about. And so I want them to do the introductions here and talk a little bit about where Tim comes from and what our background is and where we're going with this. So thanks, Chris.
Good morning. And we're very pleased to have the Qview team down here to really introduce us to this program. We're going to be a beta test site for this program, and right now we're the only other beta test site, I think, at this time. So it really is, first of all, an honor to try it out. But this actually, as Dr. Jerkovich said, stems from Jamie Anderson's project, where she wanted to try and create a database for M&Ms. And when Dr. Jerkovich joined us, he kindly left out the fact that he had actually done grand rounds up at OHSU and had seen this program in action, and so was very excited about it, and that was why Jamie and I went up to visit OHSU. And so this morning, Dr. Tim Liem, who actually created this program along with Ed, who I'm forgetting your last name, Ed, and I apologize, for OHSU. And Dr. Liem is the co-director for quality at the Knight Cardiovascular Institute at OHSU, and so he's going to be talking with us about this program.
Thank you.
Tim.
Thanks. First of all, I wanted to say thank you for inviting us down. I am a vascular surgeon by training. I feel very at home here in Sacramento for numerous reasons. One is my wife's extended family is all here in Sacramento. She's Croatian, huge Croatian community here. And second reason is that I've known Dr. Pevic and Dr. Freischlag since the late 1990s. And have been mostly on the West Coast, did a 7-year stint at University of Missouri. The other reason I feel at home here is that I've been the moderator for our Surgical Morbidity and Mortality Conference since 2010, and this conference is very much similar to ours, and strikingly similar, actually. It even starts at 6:45. I will tell you that I feel a little bit awkward about presenting here, because normally when I am a visiting professor and I give grand rounds at another teaching institution, I'm talking about some of our latest research or something like that. But for this presentation, I have a couple of purposes here. One is to give you what we have learned as far as from our attempts to standardize morbidity and mortality conference at OHSU. The second is to introduce you to this thing called Qview, which is a software that was initially developed by myself and Ed Wolf. He is a surgery IT manager at OHSU, but I am not a coder. I'm like Bones McCoy in Star Trek. I'm a doctor, not an engineer. So I helped lead the development of this, and we implemented this in OHSU in 2014 after about 4 years of development of the database, with a lot of help, input, criticism from the surgical residents and the faculty members at OHSU. And I will give you some updates with regard to where we have been since 2014. I would also like to introduce you to the group that is going to do the beta test site here, including our partners Michael Baker, Brenda Eden. They have created 60 health care products and brought them to market, and so they are very well versed with taking something that was a prototype that we developed and taking it and making it more robust and something that can be utilized at multiple institutions. This is my disclosure. I am the Chief Medical Officer for Qview, in addition to being a full-time faculty member at OHSU. I'd first like to start off by giving you a bit of a history of the M&M conference, and it starts off, well, many centuries ago in the Middle East, they had morbidity and mortality conference, but actually the modern history of the M&M conference started with the Flexner report, which was a scathing report on the status of the quality of healthcare in the United States back in the late 1800s and early 1900s. Only at Mass General Hospital, Ernest Codman, I know Dr. Jerkovich has mentioned him as well in the past. He was a surgeon at Mass General Hospital, and he created what was called the end result card. And the end result card was basically a way to analyze your complications. It was not looked upon favorably at all by the fellow surgeons at Mass General, but eventually he was able to persuade them, including the American College of Surgeons, which he was a co-founder of creating case records for M&M in 1918. A couple of decades later, Philadelphia Medical Society combines a multidisciplinary conference with anesthesia and surgeons for M&M. A decade after that, the Joint Commission, or back then JACO, Joint Commission for the Accreditation of Healthcare Organizations, did require a formal peer review process in 1952. As a result of that, in the 1960s and beyond, every state in the United States has created this thing called peer review privilege. And in Oregon, it started in 1963, and California also in the 1960s, that is supposed to help protect the discussions that occur in this room from disclosure in the case of litigation. But I will show you some of the challenges that have taken place since then. The ACGME and their updated requirements for surgical residency includes a requirement for practice-based learning and improvement, including the M&M conference as well. Is M&M conference peer review? Well, it is sort of. It is a component of peer review. M&M conference, we see, I'm sure you have thought about this as well, when discussing this with numerous chairs of surgery, surgeons, as well as our chief medical officer. Peer review has multiple facets to it. It includes these M&M conferences, formal multidisciplinary peer review, credentialing and re-credentialing, focused professional practice evaluation, and what we all have to deal with nowadays with the JACO or Joint Commission requirement, ongoing professional practice evaluations as well. That's peer review, but M&M is a little bit different from that. It is a component of peer review, but it's also to help for education for learners, whether it's a resident, a medical student, or even a faculty member. It's also meant to help identify things that might be system improvement issues, which were discussed just a few minutes ago. I will show you some of the challenges that have taken place for peer review privilege, and I'd like to digress just for about 2 to 5 minutes about some of the things that have challenged peer review privilege. And why do I show a picture of Astoria, Oregon? Astoria, some of you know it's in the northwestmost corner of Oregon. It's where they filmed The Goonies. It's where they filmed Kindergarten Cop with Arnold Schwarzenegger. But it was also in the 1980s a hotbed or the origin of some of the peer review privileged legislation that has taken place since then. I'd like to tell you a story about a surgeon, Dr. Patrick, who was a general surgeon brought in to Astoria Clinic. Astoria Clinic was a multi-specialty clinic. They hired Dr. Patrick as a new general surgeon. About a year or two after starting there, they actually offered him partnership into Astoria Clinic. He declined, preferring to go off on his own and create his own group. That was not looked upon favorably by the administrators of Astoria Clinic, and they proceeded to basically exclude him from being able to practice with them or in the community. If he sought a consult from a nephrologist or some other medical specialist, they were not very forthcoming with those consultations. If he needed some help with call coverage, they were not available. And it got so bad that when the Astoria Clinic had no other surgeons, they were actually sending their patients 50 miles away to receive surgical care as opposed to sending them to this one doctor. He sued because the Astoria Clinic actually brought up under the guise of peer review, they were complaining about some of the care that was provided. And he was brought up before the hospital board. He eventually sued, and he won the local court. It was reversed by the Ninth Circuit Court of Appeals because peer review privilege was part of Oregon state legislation. It eventually went from Ninth Circuit Court of Appeals and went to the U.S. Supreme Court. And the U.S. Supreme Court, this is just a quote from the U.S. Supreme Court, which talks about peer review privilege. And I'd just like to read this very briefly. And that what they stated was, "We are not unmindful of the policy argument that effective peer review is essential for provision of quality medical care, and that any threat of antitrust liability will prevent physicians from participating openly in peer review proceedings like we have today. This argument, however, essentially challenges the wisdom of applying antitrust or anti-competitive laws in the sphere of medical care, and as such, we properly direct to the legislative branch." And what the Supreme Court basically said was they were asking Congress to create federal legislation that then did provide peer review protection, because at that point it was all state-based. Okay? That ruling basically disbanded Astoria Clinic, and it led to the creation of the Healthcare Quality Improvement Act. At that time, Oregon Congressman Ron Wyden, who is now Senior Senator Ron Wyden of Oregon, was one of the co-sponsors of this bill. It was a federal bill that basically grants hospitals and reviewers conditional immunity from litigation. And it also created, at that time, something we all know and love, the National Practitioner Data Bank, to help address the what were called physician state hoppers who went from state to state. And that went along fairly well until about 2004, when there was a big battle in Florida between physicians and insurers who were looking for tort reform and the Trial Lawyers Association. Well, the trial lawyers actually had a better groundswell of political activity, and what they did is they were able to pass with an 83% majority a legislation in Florida that said all peer-reviewed documents, including M&M conference documents, are accessible to patients. Okay. That then led to another federal legislation, which was because that also created quite a bit of a scare in the medical community. And again, Ron Wyden is a co-sponsor of the Patient Safety and Quality Improvement Act of 2005 that then protected the documents that are what are called patient safety work products. That includes the data that are discussed at M&M as well as peer review. So why do we care about all this? Obviously, peer review, M&M conference, where it's there to help improve the quality of care for our patients. And M&M and peer review are clearly part of what we all are familiar with, the 6 aims for 21st century healthcare, published by the Institute of Medicine in 2001. It's there to help provide safety, improve the efficacy, and it's definitely patient-centered. One of the things that the Institute of Medicine report did list further besides those 6 aims is that central to many information technology applications is the automation of patient-specific clinical information, which is currently dispersed as a collection of paper records, often poorly organized, illegible, not easy to retrieve, making it impossible to manage. And that ties in quite well with some of the pain that we all face with regard to how we manage morbidity and mortality conference. This is something that, just a schematic that of our M&M process at Oregon Health and Science University. We have M&M 6:45 to 7:30, grand rounds right afterward, very similar. The residents, they have a PDF or a Word document that sits in some drive, and they either handwrite or they type onto that document. They get carried in their pocket. They hand off to the attending physician, who then reviews these cases, perhaps with legible or sometimes illegible writing. And some poor scribe has to sit there and take those documents and try to transcribe them into a computer. But what often happens is those documents sometimes were left on the podium at our M&M conference afterward. Sometimes they're all over the hospital, and it was difficult to manage all these paper documents. The pain that the residents experienced was voiced clearly to me, and that's partly why we developed this database. They create these spreadsheets. They have to create de novo PowerPoint presentations, do the review, and then where do these paper documents live? They usually go to our what's called Iron Mountain storage facility, not to be seen again. Another problem situation that we faced was, we are a participant of NSQIP just like you all are. We are a participant of UHC, which is our patient safety organization. Or perhaps there's an interdepartmental inquiry, which was perhaps mentioned earlier today at M&M. You want to have anesthesia department or orthopedics review a certain case. Well, sometimes they'll send you a document. It'll go through Microsoft Outlook email. And then if 20-30% of the time, you might get a response back. And then what do you do with that? It's hard to make system-wide improvements with an email communication stream. And as well, we had recently received an unfavorable ruling in the state of Oregon. There was a litigation against OHSU because there was our former peer review or quality improvement was not very well captured or encapsulated. The Supreme Court in Oregon said, your documents, you have no peer review system because it's not a system. It's all discombobulated. You've got emails here, paper documents there. So they said all this is not privileged unless you have some system that is encapsulated. That was a ruling that we received last year. This is something that has been seen nationwide. Internal medicine education specialist from Boston University has also described what I'm saying. Despite being universally familiar, M&M Conference lacks a precise definition and a standard format or identified goals, but they did describe that there is a dual format for a dual purpose for the M&M Conference for education and system improvement. Other providers or educators have described the same thing, variable patient selection criteria. Is it educational interest? Is it system improvement? We don't know which. And less than 50% of medicine residencies do have an established method for discussing errors. Fortunately, there have been some efforts nationwide to improve or standardize the Morbidity and Mortality Conference. Pediatricians from Vanderbilt University have demonstrated that a standardized and consistent approach to case reviews leads to better understanding of factors for adverse events, formulating plans for improvement, and fosters non-judgmental case discussions, which is what was obviously true here as well. One of my partners, Erica Mitchell, she's a vascular surgeon and at OHSU. Her primary research interest is in surgical education. She and I did a study looking at the S-bar. I'm sure many of you are familiar with that, using an S-bar standardized communication tool for discussing morbidity and mortality as a template, situation, background, assessment, and most importantly, recommendations. And what she found was that it did improve the quality of the presentations and improve the educational outcomes when we did actual questions of what the learnings were after the M&M process occurred. That led us to develop this system that Ed coded called Qview. It wasn't named Qview at the time, but it is actually now a healthcare app that lives on our server at OHSU. This app is available from any computer. It's available from home. We log in with our standard OHSU ID. Back then, when we first started this program in 2014, it was just in the Department of Surgery, but now it's actually in 8 departments at OHSU, including medicine, family, all the surgical specialties, including neurosurgery, head and neck surgery, orthopedics, etc. And I'm just going to go through a little bit of a tour of our M&M database that we call Qview. And again, this is just a database that was created in Microsoft Access, but Qview is actually, our partners have 3 or 4 software engineers who are actually converting this into something that is going to be much more robust and much more configurable. What we have is, right now, this is the current homepage. For our M&M conference, we have the schedule of who is presenting at M&M, the residents who are responsible for that presentation, as well as the grand rounds. Dr. Hunter, our chair of surgery, wanted us to have CME available for the M&M conference as well, so we did add a CME component, and we asked the residents to submit 2 questions for every case that they present, so that the attending physicians, if they answer them correctly, 75%, they get an hour of CME, maintenance of certification credit, for the M&M conference. In addition, we have the document library, which is a repository for the practice guidelines that I'm sure you all utilize as well. Some of the things that the residents also complained about, and this is true for me when I was a surgical resident as well. When you start a service, you start the service running, and you don't necessarily get a great orientation. Occasionally, a service might provide you with a practice protocol guideline. You might carry it in your pocket, you might lose it, but this is something as a repository for those guidelines. In addition, some of the department-approved resources for the treatment of certain conditions are also published in this document library. The residents enter the cases, or the attendings enter the cases, with demographic information. We use a harm score called the Qview harm score. And then we enter the patient information, including the admit date. The entries are attending specific, resident specific. There is some free text of the clinical course. We then have discrete variables for the procedures and the complications. So if you are a vascular surgeon, there are a set of index cases that you want to track. Those are all populated in here, and each division or each service gets its own group of index cases that they want to track. The complications that we add into the system are actually the NSQIP complications, in addition to these specialty-specific complications that are not necessarily present in the NSQIP outcomes. When a resident submits a case, it usually takes a few minutes to submit each case. Then attending physician does the review actually right there at the M&M conference, and I'm glad to see that there were so many laptops here, because that is a change in the workflow for attending physicians who are doing reviews. We actually do the reviews live as the case is proceeding, including in trying to capture the discussion as well. There are peer review conclusions that are listed here. Recommended actions are going to be configurable. We heard a discussion today about policy, whether there's a policy present. If there's a policy that's present and it wasn't followed, those are all what we call flags that can be configured for each department, so that when you do a query and look up you could look up every policy that was not followed if you followed this M&M database format. This also has, we don't have a communication tool yet, but we are creating one for the enterprise version that would be available. And so you can see here that the second thing is, on that checkbox, and that's circled in red, is refer to other service. Right now it's just a checkbox, but what's going to happen is you check that box, and there's actually going to be a communication tool which will communicate with the other department so that they can then respond to you, and the documents from 2 departments will then be merged together so that there could be an ongoing dialogue between departments, between specialties. Okay. When a resident submits a case, it pre-populates this, what we call the View Cases page. The View Cases page shows all the patients that have been submitted over a certain period of time. You can see up here that you can change the start and end date when what is visible here on this View Cases screen. And this allows the residents to avoid any of those paper documents that they were carrying in their pockets in the past. When a resident switched services, now it's fairly clear. One of the benefits that we didn't realize was that residents switch services every month or every 6 weeks. they need to know who was presented at M&M and who wasn't. So when a new resident comes onto the team, they look at the View Cases page and they see which patients have been submitted, which patients have been reviewed by the attending, and which ones still need to be presented. Okay. The other benefit for the residents that they wanted was that once you create this View Cases screen, there's a little button down below that says Create PowerPoint, and it actually creates the PowerPoint for you with a standardized template for this SBAR, Situation Background Assessment and Recommendations. It de-identifies the PowerPoint. Just like what I saw here earlier, we use the patient's initials and the age, but we don't use the medical record number or the full name. We have the attending and the resident physician, the diagnosis, procedure, and complications, and these are also going to be configurable. It also states at the bottom who created the PowerPoint. And this is just a slide showing how the PowerPoint is created. You click on this, just a test service with only a few cases, fake cases that I've submitted. And then you click the button, and it creates the PowerPoint for you so that there's, it's a little bit more efficient for the resident who is doing the presentation. And it shows who created the PowerPoint. It has hyperlinks so that when someone asks about a particular case, the hyperlinks show up as the next slide, and then it shows everything that you've submitted in your M&M database so that you can have an intelligent conversation with the rest of the audience in the M&M conference. And most importantly, we do a mini root cause analysis and recommendations, which are then going to be transferred to the department of quality group, as well as to potentially the quality specialists in the hospital. So far, since 2014, we've had 2,700 patients entered into the Department of Surgery for our M&M database, 2,900 procedures. We identify NISQIP areas for improvement. We target NISQIP areas for improvement, select harm scores, certain policy and system issues. Erica Mitchell, our Vice Chair for Quality in the Department of Surgery, works with the hospital to take these issues that are identified and then tries to transfer them to make some institutional learning. Procedure and outcome categories, these are the top 10 that are shown here for procedures, the top 10 most frequent outcome categories, and there's some policy and system issues that are also identified fairly frequently during our M&M conference. Thus far, it was actually unexpectedly popular amongst other departments. Various medical and surgical specialties are utilizing this at OHSU. Like I said, we're creating a communication tool. There's a report generator so that a surgeon, the chair, the quality physician in your department can look up things on a surgeon-specific level, resident-specific level, as well as the new enterprise version is going to be what's called HL7 compatible, so that it will be able to drag in information from whatever electronic health record you use and perhaps populate the documents into the database itself. And this is just a view of the enterprise version that you would be seeing here as a beta test site. This is a lot cleaner than our old Microsoft Access database. This would be a typical home page for that might have an inbox for an attending physician. Could you review this particular case? Then the attending physician can review the case and then submit the response back to the referring department or physician. The data entry is more robust, it's cleaner, and things are all procedure-specific, complication-specific. You can enter cases without a procedure, such as a delay in diagnosis, and you can enter multiple procedures and multiple complications per procedure. So that's about it. We're looking forward to having UC Davis as an external test site for the database. I think our residents and our faculty members have taken to it fairly rapidly and with minimal instruction on our part, mostly because they helped design it. And I did definitely want to acknowledge Ed, who did the coding, as well as Michael Baker and Brenda Eden, the surgical residents at OHSU, as well as John Hunter, my chair of surgery. Thank you.
Jim?
Sure.
Scott? Chief
As
of the VA.
a web-based product, was there any opposition to using or barrier to using this at the Portland VA? Specifically, all their faculty or your faculty?
Exactly. We are still not in the Portland VA. That has been one of the obstacles. It is a federal crime to take VA patient information and store it in a non-VA approved repository. So currently we are working with the VA to actually, there is a precedent for storing VA research patient information at OHSU, and we are currently trying to tag along with that precedent and have VA patients also stored here. And that's one of the things that has been a bit disappointing in that when we have M&M conference, when we discuss OHSU patients, we are sitting there having a robust discussion and it's all documented. And when we sit there for the VA patients, I kind of have to, I sit like this and I don't do any typing because it's not allowed as yet, but we're working on it.
You know, the research issue has also been a barrier for us. We can't store research information outside the VA, which means we can't use our wonderful statisticians.
Mm-hmm.
They aren't going to come over to the VA to help us with that. I had to give back a $250,000 grant a few years ago for just that reason. Very frustrating.
And we previously had 2 IRBs. If you were going to do research at the VA and OHSU, that you had to submit for IRB approval at both institutions. And recently, about a year and a half ago, they combined them into one IRB. So that did streamline things a little bit. Dr. Pevick.
Very interesting presentation, Tim. Do you have to enter all the patients in, not just complications? How do you get the denominator if you're trying to get any data?
Right.
You don't enter all the patients. That's the first question. The second question is, we're entering already into multiple databases.
Mm-hmm.
We've got VQI, we've got NISQIP,
Mm-hmm.
and now potentially we have this.
Mm-hmm.
How do you afford to do all that? And then the third is, if you want to get a denominator for complications, there are all different hierarchies you could look at. So you could say I'm going to look at my own area. So we got a complication of hemorrhage. We're going to look for all vascular patients.
Mm-hmm.
We can look for aortic patients. We can look for endovascular, open aortic, endovascular aortic, lower extremity. Are you with this system? Do you enter all the patients? How do you manage that from a financial and personnel standpoint? And then can you query on multiple different hierarchies to look at percentage of complications? Sure,
absolutely. That's a great question. We see this as not a replacement for VQI. It's not a replacement for NISQIP. They have very different workflows for how you get that data. The NISQIP data tells you how you're doing to a certain degree, but it doesn't delve into the individual discussion about what of that particular patient. We see this as complementary. We use this in a complementary fashion to NISQIP. As far as the denominator, you're correct. It does not have a denominator unless you enter all your cases. Our plastic surgeons have a design to enter all their cases because they want to use this as their primary database. And if they want to do that, that's fine. They have a robust number of index cases that they have imported into the system. So I think that would be more dependent on what the individual service or division wants to do with the database. It actually doesn't add any more work for our department because the residents were doing fairly inefficient workflow for entering cases on paper. They were the documents were living in a secure X drive, and so it was being done in a somewhat more haphazard fashion, and now it's being done in a more uniform fashion. And then so there was.
I guess it's you kind of all the same
Yeah,
thing. So
yeah.
You know, it depends on how you want to use the tool. So I guess my follow-up question is, if you're not entering all the patients and there's not a denominator, I could see where at least you have some place where you're saving the information, but
Sure.
is it useful?
Sure.
Is it
Right.
queryable?
Yes, so you can query this system for, let's say in vascular surgery, I want to look up every hemorrhage and hematoma that has been entered into the system on a surgeon-specific, resident-specific, date-specific procedure specific. So you could look up hemorrhage and hematoma for aneurysms. You could look up surgical site infection for mastectomies, and look up various common themes that are occurring. For example, this actually allowed us to look at our hemorrhage and hematoma rate, which was pretty high, and look at what the commonalities were. Instead of having to wait 6 months or 3 months to get our numbers back from University Health Systems Consortium or from NISQIP, we actually could go into the system, look up every hemorrhage and hematoma, and see that, hey, we were pretty aggressive with our perioperative anticoagulation. People were with AFib and CHAD's vast classification, class 1 or 2, were being put on therapeutic anticoagulation on post-op day 1, allowing us to say, we're not going to do that anymore.
So Rick Bold, I think Rick had a question.
Yeah. So tagging on actually that last discussion, there's been a proliferation of databases that have been used for a variety of efforts, and you were highlighting the quality improvement aspect. But how do you reconcile the fidelity of the data across the databases? UHC may report one set because they're coded by billers. NISQIP reports another incidence of hemorrhage. They're coded by nurses. And now you're coding complications based on resident and attending evaluation. And we've all recognized that those databases have completely different incidences and prevalences of these complications. So how do you reconcile across that, particularly in the setting of quality improvement?
Absolutely. So this is not to replace NISQIP or UHC. The hospital is going to, our hospital says UHC is our patient safety organization, and it's here to stay, like it or not. What happens is when we get our numbers back from, actually, you're right, the coders do all the coding for UHC. We get these numbers back and they say, you know, we say our hemorrhage and hematoma rate or our mortality rate is what? You know, we say, and those numbers are very disparate from the NISQIP numbers. And what the quality specialists in our department do is when they actually go into the system and they actually look at the patients and see if there's any agreement. About, from what I've seen, 70–80% of the patients that are in UHC that are identified as perhaps causing us to be an outlier for hemorrhage and hematoma are actually present in NISQIP. Not 100% because not everyone's, all the residents and faculty members are not capturing or entering the patients into the system, but they're using it as in a complementary fashion. They're taking the numbers that we get as feedback from NISQIP and UHC, and then they're looking back and saying, hey, you had a mortality from an aneurysm. Was that discussed in your M&M? What were the learnings from it? Was this really a hemorrhage and hematoma? Or was this just a minimal, non-clinically significant bruise? So it allows us to look back into this system and say, yes, this was something that we felt was a real complication, or no, that was a clinically insignificant thing. And what we try to do now is we try to actually get feedback from our quality specialists before data is submitted to UHC. So it's actually made it more time efficient with regard to, for the quality specialists, the nurses in the hospital, as well as for the physicians who need to look up a particular case. Instead of having to look up 4 mortalities for aneurysms from 2015, they are all in here. And so my chair, Chief of Vascular, Greg Moneta, he doesn't have to go into our EPIC system and look up every one of those mortalities that were identified by UHC. They actually just go into the Qview system and look up what, if there are any improvements that could have been made.
I saw another question.
Well, I've
Scott.
got sort of an angling question. We recognize, as you mentioned, and Rich mentioned, the varying definitions between these systems, SWIFT versus this system versus others. As this tool proliferates, and as we look at rates generated by analysis of large numbers of patients, we should be able to get to a point where we can start adjusting the percentages generated by one system to estimate what the complication rate would be in another.
Yes.
I guess the assumption is that if the set of complications under one definitional set is high, that it would be similarly high in another, and you could correct the percentage to generate some sort of standardized complication rate.
And we've definitely, that is in the works, to have some type of predictive, once you have enough numbers with regard to trending, let's say trending for C. diff infections or trending for surgical site infections, whether it's seasonal or whether it's in June or July, those things will eventually be able to be looked at so that you could have some type of predictive analytics, perhaps combining some of the data from EPIC and the data from UHC, combining them together to create an analytic tool. Yeah.
Is there a category that you assign for root cause to the, do you just categorize by clinical diagnoses, or do you have a root cause analysis that gets included? The slide set for this S-bar includes a slide for a mini root cause analysis. You know, you've seen the fishbone diagram, the Ishikawa, the fishbone that addresses potential for instrument factors, human factors, technical error, and other things, communication. So all those things are integrated into the S-bar template so that a resident usually discusses all those things at our M&M. Yes.
Well, for those of you who are interested in ongoing discussion, we're going to meet with Dr. Liem and the Qview developers over the next couple hours to talk about some more details about implementation of this. I want to thank you all for your attention for the last 2 hours, right on time, and please give a round of applause. Thank you.